Hello friends, welcome to Dental Lecture, your exclusive dental lecture series. Today we'll be seeing on endodontics. I would say definitely have a look at this video just before your exam because this is more of a synopsis rather than a very long exhaustive lecture. So when it comes to endo, the first and foremost favorite questions of examiners are in terms of pulpal and periapical diagnosis of a tooth. And the diagnosis can be made based on the hot or cold test and an electric pulp test, the clinical signs and symptoms of patient, and tender to percussion. So for example, they can give you a scenario where the hot or cold response is a short response with an exaggerated response on EPT, and the patient presented with symptoms of immediate onset of pain, sharp and difficult to locate, and there was no tender on percussion. So if this is a case scenario given to you, then the diagnosis would be reversible pulpitis. So likewise, you'll have to know for irreversible pulpitis. When it comes to pulp necrosis and previously initiated endodontic treatment, there will be absolutely no response in hot or cold and the EPT because the pulp tissue itself is gone. So now that you know your pulpal diagnosis, let's move on to the periapical diagnosis. This is made based on clinical signs and symptoms, clinical tests, so that is your tender on percussion, and the radiographic findings. Let's see an example. If the patient reports to you with a tenderness on chewing and upon clinical examination there was tender to percussion and radiographic findings reveal that there is intact periodontal ligament space with loss of lamina dura, then the patient is likely to have symptomatic apical periodontitis. Likewise, we have other periapical diagnosis, which is asymptomatic apical periodontitis, chronic apical abscess, acute apical abscess, and finally condensing osteitis. Go through this table and each of this can be important MCQ question. When it comes to endodontic instruments, it is important that you know the difference between reamers, K-files and H-files, that is the H-tone files. So in the cross section, the reamers are triangular, K-files are usually twisted square, and the H-tone files are usually in a teardrop sign. And in terms of rake angle, reamers are at 60 degrees, K-files are 90 or 60 degrees, and there is no rake angle in H-tone files. The function of each of these files is that the cutting action of a reamer is a quarter turn rotation and then pull or withdraw the file. When it comes to K file, you do an apparent push and pull motion only. And in headstrong files, there is only pull action. And in terms of flexibility, the least flexible I can say is the headstrong file as it has no rake angle, and because it's the least flexibility than the other two files, it also has more likely tendency for fracture. And since the headstrong file has only a pull action, it has the least tendency for debris extrusion, unlike the K files where the debris extrusion is more likely with a push and pull action. This is yet another common question asked in endodontics regarding what are the commonly used pulp tests to check the vitality of a tooth. So that would be heat test, cold test, electric pulp test, test cavity, laser Doppler flowmetry, and pulse oximetry. Heat test is essentially done using a heated GP stick or a ball burnisher, first tested on the control tooth and then compared with the tooth in question. Cold test is done using ice sticks or endofrost if available. An electric pulp test is essentially done using specific devices which has varying currents or wavelengths of electricity passed on the tip. And if nothing is conclusive, we can always try a test cavity. And the recent advances are laser Doppler flowmetry and pulse oximetry. There is a special test called as bite test, which is done using a tooth sleuth, and this is more important when you're coming to diagnose a condition called as cracked tooth syndrome. And when there are tight contacts and junctions between the two teeth and it is difficult to identify a proximal caries even with a bite wing radiograph, then trans-elimination is the investigation of choice. Last but not the least, any endodontic diagnosis needs a radiograph, which is helpful in identifying the caries assessment, bone loss, root anatomy, the crown-root ratio, periodontal ligament, whether it is intact, thick or diffuse, lamina dura, and the presence of pulp stones. Now, Let us interpret the findings of the thermal test, which is the heat or the cold. If it is true positive, then it is indicative that the pulp tissue can either be normal, reversible pulpitis if there is a short response, and irreversible pulpitis if there is a lingering response. A false positive is possible if you have contacted the gingiva or the adjacent tooth, which is apparently a normal tooth. The thermal test can be negative, a true negative, if the treatment is previously initiated or the pulp is completely dead and necrotic. And a false negative is possible if the canal is calcified. Let's interpret the EPT test, and it's positive. It means the tooth is vital or having pulpitis. And if the test is negative, it means that probably there is a previous treatment initiated, or the teeth has undergone pulpal necrosis, or the canal is calcified. False positives are possible if you've accidentally contacted the gingiva or the adjacent tooth. Once the access cavity is opened, the most important step is working length determination. It is nothing but the distance from the coronal reference point to the position where the preparation has terminated. And there are several techniques to determine the working length, which includes radiograph, electronic apex locator, which is almost 90% accurate, tactile sensitivity of the dentist, patient sensation. However, this can be very subjective, especially if the patient is in pain, and hemorrhage. So if you're preparing for the canal and suddenly the bleeding starts out of nowhere, then it is likely that you've over-instrumented the canal. So when you're learning about the root apex, it's important that you know the key anatomical landmarks of the root apex. Let's see one by one. So the radiographic apex is the apex that you see on the radiograph. It is the tip of the root that appears on a dental x-ray, and ideally you should stop the obturation 1 to 2 mm short of the radiographic apex. And when I say the word anatomic apex, it is nothing but the vertex of the tooth root where the neurovascular bundle enters. And the word apical foramen is the main opening at the end of the root canal where the pulp tissue communicates with the periodontal tissue. And it's usually located 0.5 to 0.7 mm away from the anatomic and the radiographic apex. And apical constriction is nothing but the narrowest part of the root canal, and it's usually located again 0.5 to 0.7 mm coronal to the apical foramen. And this is generally considered the ideal point where you can terminate the root canal preparation and the filing, and this coincides with the radiographic apex. So let's see the purpose of obturation. Number 1 is to seal the apex and the coronal part of the canal, eliminate all the avenues of leakage into the root canal system, seal the irritants into the system so that it cannot be removed during the cleaning and shaping procedures. Now that we know the basics of endodontics, let's see specific MCQ related questions. So they can ask you questions about what are the various types of each medication, irrigation, sealers. They can ask you about the components, the percentage. So let's see as follows. The first one is root canal medication. The common types that are available in the market is non-setting calcium hydroxide paste, which is available called as hypocal or ultracal. You have antibiotic or steroid paste, which is the Odento paste, and you have iodine containing paste, which is commonly available here is Vitapex, and you have zinc oxide eugenol, which is the traditional mixing of zinc oxide powder and eugenol liquid. The components of ideal root canal medications are zinc oxide, eugenol, barium sulfate, bismuth subcarbonate, bismuth subnitrate, and you have additives such as sodium borate, stabilite resin, thymol iodide, and Canada balsam. Now that you know about the medications, let's move on to the ideal irrigation. So you have several irrigants available in the market, such as sodium hypochlorite, which tends to remove the organic debris. And then you have EDTA, which is a calcium ion chelating agent, and other lubricants which will remove the fluids and smear layer from the canal. An ideal irrigant should have adequate contact and exposure time, and the mechanical agitation with a file size of 8 to the working length after each instrumentation helps in irrigant penetration. Ideally, there is no proven method of irrigation and the seconds of irrigation. However, you can do almost 20 seconds of hypochlorite, sodium hypochlorite up to 3 times, and that will give a broad antimicrobial activity. And it tends to dissolve the pulp remnants, and it has to be non-irritant to the periradicular area to be called as an ideal irrigation material. When it comes to ideal sealer, you have the following properties. It needs to be tacky when mixed, and it should have good adhesion towards the canals. It must be bacteriostatic, establish a good hermetic seal, and it cannot shrink on setting, and it should be able to easily mix with ample working time, and it should be radio opaque, which will help us to view on the radiographs. It should be essentially non-staining, bond to dentin, and be insoluble in tissue fluids, however soluble in solvent if at all removal is required. The commonly available sealers in the market are calcium hydroxide based sealer, which is Sealepex. You have the resin based sealer, and now this is currently the most popular, which is AH+. You have the glass ionomer sealers such as Ketac Endo, silicon based sealers such as Gutaflow, methacrylate resin based sealers such as Endores, and calcium silicate based sealers such as Neo Sealer. Now that you've seen the ideal properties of a medicament, ideal irrigation, ideal sealer, now let's come to the most important ideal obturation material, which is usually the gutta perca. And this is a very famous, important MCQ question in terms of composition. And students tend to make a mistake here because they assume the major composition is gutta perca. However, it is only 20%, and then the remaining 65% is zinc oxide, 10% is radio opacifier, and 5% is plasticizer. The ideal properties of an obturation material is that it should be easily manipulated with ample working time. It must be dimensionally stable once inserted and seal the canal efficiently laterally and apically. It must be non-irritating to the periapical tissues, be impervious to moisture, and be non-porous. It should be unaffected by tissue fluids and inhibits bacterial growth. It must be radio opaque and does not stain, and it should be easily removed if at all required using solvents. Now that we know all about the ideal properties of medicament, sealer, and gutta perca, let's see about the obturation techniques. There are several techniques, of which the gold standard is the cold lateral compaction. Apart from this, we have single cone, warm lateral compaction, warm vertical compaction, injectable gutta perca, warm GP on a carrier, mechanically thermoplasticized, and chemically softened. Now that I know how to do obturation, how will I assess my obturation that it is successful? We have a few radiographic signs. The first one being the gutta perca should end less than 2 mm from the radiographic apex, and overfill is not desirable. A homogeneous compaction is necessary, and it must be well adapted to the canal walls, and there must be no signs of perforation. Endodontics is challenging. Endodontic errors is even more challenging. So let's broadly classify the endodontic errors into preoperative, which is purely because of misdiagnosis. The first few slides which I was talking about the pulpal and periapical diagnosis. Intraoperative endodontic errors, which is including hypochlorite accidents. It goes beyond the root canal, separated instruments, aspiration or ingestion of any irrigation fluids, perforation of a canal, very common among mandibular molars, or ledge formation. When it comes to post-op complications, we have pain and infection. When it comes to surgical endodontics, it is chosen when there is difficulty in access to root canal, when there is difficulty in achieving apical seal using a regular orthograde root canal, and to remove any apical fenestration. Then we perform apical surgery. So let's see the indication: inability to treat non-surgically because of difficult anatomy, failure of non-surgical root canal treatment, persistent apical exudate into the canal during the non-surgical treatment, when there is a need for biopsy, for example, there is a periapical cyst, need for drainage, iatrogenic causes such as root canal perforation, creation of apical seal, and finally curettage of apical infection or granulation tissue. There can be a few contraindications to this procedures, especially if it's close to the neurovascular bundle, when there is a maxillary sinus involvement, when there is second mandibular molar because there will be a very thick buccal bone. Deep periodontal pockets are contraindications for this surgery, and also a list of medical conditions of the patient such as diabetes mellitus, osteoradionecrosis, pregnancy, and bleeding disorders are relative contraindications for apical surgery. Let me quickly run through the steps of an apical surgery. Administer anesthesia and do a flap reflection. You can choose based on the anatomy of the tooth. So it can be semilunar, trapezoidal, triangular, submarginal, and papilla preservation flap. So you can choose one of these flap designs based on the anatomy and the position of the flap. And then you do an osteectomy. You remove a small piece of bone around the root apex and then perform an apical curettage. Epicoectomy, that is, you cut the apical 1/3 of the root, and then you do a retrograde tooth preparation and then retrofill, essentially using a mineral trioxide aggregate, or famously called as MTA, and then suture the flap back into position. So this is in short about the apical surgery. So I hope you've understood something so far, and in case you have any doubts, please feel free to comment below. I will try my best to answer your questions. And also, if you've seen that it is hardly less than 20 minutes, I've covered the entire endodontics. It's more like a synopsis. So do save this video so that you can watch this video right before your exam, just to have a brush up of the entire endodontics, the key points that you need to know from an exam perspective. And if in case you want any particular topic in endodontics to be taught in detail, do comment below and I will try my best to give you detailed versions of the topics that are challenging for you. And this is me signing off on Dentalect, and do follow me for future videos. Bye.